Olá pessoal, aqui é Renato Centroni do Happy Auer Podcast. Estamos no International Myeloma Society e hoje temos convidados importantes que a gente vai debater hoje. Vamos lá, Fábio.
Thank you, Renato. Our guest today is Professor Rajkumar from Mayo Clinic. He's one of the most important personalities in the care of myeloma, and it's an honor to have you here with us, Professor Rajkumar. And I like to say it's an honor for me also because I'm a Twitter follower. I love your tweets, even though Twitter is hard to access in Brazil nowadays. It's really nice of you to be here with us, and it's a pleasure. And to get started, I think we're going to ask you, how do you see having the first IMS meeting here in Latin America and in Brazil, and what is the importance of this for the treatment of patients with myeloma?
Hi, thank you so much for having me. It is really a pleasure to be here. This is my first trip to Brazil, and but we have visited other South American countries before, and we have a very deep fondness for South America, and my wife and I really enjoyed the last 1 week we have already spent in Brazil. I'm so glad that the IMS has come here for this meeting. It recognizes that Latin America is has a very diverse and heterogeneous problem with myeloma, with access to drugs and differences in standards of care, and it's important to engage and be present. As part of the International Myeloma Foundation, we do have a Latin America presence, and I've worked very closely with Christine Battistini, who's on the board of the IMF, and also with Dr. Hungria and others to engage with Brazil specifically and Latin America through the IMF. But the IMS coming here is really great, and I feel like the meeting itself is just unbelievable. First day itself is just like outstanding. Having a really wonderful time.
So in the past years, we have launch of several drugs for multiple myeloma, and I guess now we have more questions than answers. So I know it's hard for designing trials, but if you would design a trial with what we have now, how would you think to build this trial? How would you manage this? What is your design possibility that you think it is really important to answer what we need now?
So in terms of clinical trials, it's really hard to secure funding for investigator-initiated trials. But that's where I think the need is, because a lot of the pharmaceutical company trials are designed primarily towards regulatory approval, getting the drug on the market. But how best to use that drug, how long to give it, at what dose, can we stop it and save money in that sense? Those are trials that only we in academics can do. Even small phase 2 trials that say you do here could have a huge impact. I mean, for example, say a drug like teclistamab is approved for every 2 weeks or whatever indefinitely. If you do a trial in which you say, like, in Brazil, the cost is so much, so we decided we'll just do, once the patients responded, switch to every 3 months, 1 year and stop. We've treated 50 patients. All of them are doing so well. It's an easy trial, but at the same time, you get meaningful data that other countries haven't produced yet. But on the bigger scale, if you want to do where is the field going next, you have to say, where are we right now? We are saying everybody should get a quadruplet for induction, transplant, and maintenance, or a quadruplet for like 8 cycles and then maintenance. If that's the standard of care, how do you improve on that? One group of countries or investigators could really go into how to improve on that by increasing the intensity, the duration, changing to bispecifics, adding CAR-T, whatnot. But another group of investigators, and particularly if cost and resources are a constraint, here could take on the challenge of, how do I minimize the toxicity with these regimens? How do I shorten the duration of therapy? Can I substitute treatments which are less expensive? For example, Darolen is going to be far more expensive than darabotazimab. And no one does a comparative trial of the two. If we are going to give doublet maintenance, one person was asking today, should I do Dara-Len or Dara-Len or bortezomib-Len? And the answer was, we don't know. Well, that's a trial that will never get done in the United States, that I can tell you. But it's a trial that you could do because it actually will help solve a problem for cost and provide data that's meaningful that others can benefit from. So you want to really look at what are the questions that others are not answering that are actually really important for us to know the answer to, and do those trials. It does not have to be the trial that improves overall survival. It can be trials that really help with quality of life, cost, those kind of considerations.
I think your answer is perfect. Can you comment the difference of clinical trial, real world evidence trials? So we can see on clinical trials frail patients or renal failure patients. Could you comment about that, the difference to... Sometimes I can recognize my patient on clinical trials and can achieve the same results on my practice. Can you comment about that, please?
So I would say that for every 100 questions you want to ask in medicine, we have money and time to answer maybe one question with a clinical trial. The remaining 99, we have to use our experience and real world data because we just don't have the time or the money to answer that. It would be nice to have a randomized trial to address every issue, but we don't have the time. So I've become a real fan of well-designed real world studies that help answer questions that no one is answering with a clinical trial. At Mayo, at least I'll give you an example, we started a trial this is a real world trial, and it's looking at all patients in the US who are currently getting treated for newly diagnosed myeloma with either VRD, DRD, or Dara-VRD. We feel like if we collect a large sample size of such patients, then we can really compare between these three regimens for which there is no head-to-head. At least for DRD versus VRD, there isn't. And we can also find out how do African Americans respond? How do frail patients who are not included in clinical trials respond? How do patients with renal failure who didn't enter trials respond? So I think designing a good, not one, but many real world studies is both cost effective, less time, and the answers can really change practice because those are not questions that will be answered in clinical trials. So I'm a supporter of that, and really again take to heart and really think about what kind of data you have, and as long as you have a large enough sample size, you can adjust for various confounders and then provide results that might be meaningful for people.
You quickly mentioned the issue of costs, and I have seen you tweet a lot about the cost of medicines. In particular, you live in the US, but you are worried about the costs of drugs over there. But overall, I think that medicine as a whole is getting more and more expensive. And oncology in particular is getting prohibitively expensive. So how do you feel when you see all those new drugs getting approved and treatments that last for indefinite times, and what do you think what we should do and discuss about the cost of medical therapy for myeloma?
I think first of all, more and more investigators really need to notice this issue and start speaking out, both when the trials are designed and when the trials are interpreted. They have to really take into account, is this benefit really worth the cost? Not everything that provides benefit is actually worth the expense. And which types of trials will unnecessarily increase cost without meaningful benefit? Like, for example, indefinite versus no treatment. You have to really wonder, is that really going to help reduce costs for our patients? And advocate with pharma for the right type of trial designs that will allow that. In terms of what can we do, I think it's a handicap. I've thought about this for so long. The problem we have right now, for your listeners is that the US is a large country with enormous resources, but does not negotiate the price of drugs. As a result, pharma can walk away from just about any other country because if they don't sell drug in Brazil, whatever that revenue is, they can make it up by adjusting the price in the US. So all of the negotiating hands are tied. So I really feel like the only way drug costs will come down is if the US starts negotiating prices, just like the other developed countries do. And so then pharma will price drugs more reasonably proportional to the value it provides. Like if it provides 6-month PFS improvement, that's worth so much compared to 2 years and so on. Until that happens, they're going to walk away from countries saying that we'll give you this new drug, but only at this cost. If you don't want it, well, too bad, you won't have it. And that really ties your hand, and it really makes it difficult. The other one is access to generics and biosimilars in a very timely manner, which is also a problem. And that some of it is also laws within each country. And even Brazil, I've heard, has laws that have affected the ability of generics to enter the country, which then affects thing. And then the quality of the generics themselves. I've also heard that some of the generics are producing side effects more than what people have seen with the brand name drug, and some physicians are unwilling to change. So those are areas we can work on to try and see the thing. If at all there is a silver lining starting this year, starting next year, 2026, the US can negotiate prices of drugs for at least 10 drugs to start with, and slowly they will start negotiating for more and more drugs, and that could have an effect on drug prices worldwide, because if the US price is lower, then it helps everywhere else. It is a big problem, and I feel like the more we speak up about it, the more we'll have an impact.
Continue on this topic. I was really appalled when Kantarjian, in a recent meeting, said the standard of care for CML should be generic imatinib for everybody. And I remember in one of your talks that you said that maybe myeloma should try to do things as leukemia doctors do. So do you think if maybe designing trials in risk stratified subsets, so designing trial with bispecifics and CAR-T for high-risk patients and for standard patients, maybe improve those treatments we already have, do you think this will have an impact for the patients and cost-effective as well?
And can I add some question with him? And the impact of MRD negative, especially in standard risk. So it's a important tool. You, in your clinical practice, do you feel comfortable to stop treatment in patients with MRD negative and standard risk to combining this tailoring of approach of these patients?
Yeah, there are like 3 questions here.
Yeah, 3.
But let me ask you, you said you are appalled or you're happy?
Happy.
You're happy. You're happy.
Yeah.
You're
surprising to see.
Yeah, you're surprised and happy, right? Like, so first I will answer that. I am a very big fan of Hagop Kantarjian, and he and I have written papers together on the cost of medicines. And Hagop has the guts to get up and say that if you can get CML for one patient treated for their whole lifetime in the US for $20,000, I find it hard to justify giving a second generation TKI, which is $150,000 per year in the first line. Therefore, he said imatinib might be the best in terms of value, cost-effective care for frontline CML. I was recently at a meeting with him and I asked him point blank, hey, Gop, will you tell this audience, like, you do prefer this? And he said, yes, I do, because why would you spend the money? The main message is that is the kind of stand I feel myeloma experts need to take, because we do have a voice. And if we are not willing to say, this treatment is great, but it's not worth it because, for example, lenalidomide versus iberdomide, I've been telling BMS, if you show me like iberdomide is way better than lenalidomide, that's one thing. But I'm not going to be willing to substitute a drug that has become generic and very, very low cost with something that provides some marginal benefit, which costs a ton of money, unless there's some extra benefit you get, like survival or something like that. So if we are not willing to speak up, then in the same way as Hagop Kantarjian does, then we won't help our patients as much. So I think I really like look at him as a role model for how we as physicians can help with the cost issue. In terms of whether we should design trials with standard risk with different intentions than with the high risk patients, probably. I think the main thing is like, if somebody is 65, 70 and they are standard risk and they can live 15, 13 years, 14 years, that might be okay for them. But, unfortunately, we are having diagnosis of myeloma at 40 years and 50 years. And for somebody like that, 15 extra years doesn't seem to be enough. So I think for the time being, we should still be committed to improving the outcomes for both groups, not be satisfied with the 15, even for standard risk. Yes, at the same time, as I told you here, you might be you could let some people do those kind of trials, but in parallel, you do trials where you'll just make the existing DARA VRD transplant maintenance more easy, time limited, something like that. That's a good idea. For example, I really don't think consolidation adds anything except 3 more cycles of cost. So why consolidate? You've already given the transplant. There's no proof that the consolidation helps over the maintenance. The stamina trial didn't show any such thing. So those are the critical things that to do. MRD to decide when to stop therapy would be another great thing, because that'll save toxicity, save money, save patients the inconvenience of getting tested or coming for treatment. So I think many people are reluctant because we don't have randomized data. There are trials going on in the US. There's the 1803 SWOG trial, which is randomizing Dara-Len versus Len. And in both arms, patients can stop when they get MRD negative after 1 or 2 years, to see if stopping therapy is just as good as continuing therapy. So that I like those kind of designs. We need to do those because at least that's one way of reducing the treatment duration. We have another trial in that's not yet read out in ECOG, which is just 2 years of Len versus indefinite for maintenance. That's the other way to do it, is to just do a head-to-head, time-limited versus continuous, and see which is better. Those kind of trials we can do. So Canada is doing now one for DARA RD frontline. One arm is, I think, 2 or 3 years and stop, and the other one is time till progression, like the Maya trial. If they show that 2-3 years is fine and just same benefit, we just save huge amounts of time and toxicity and cost with that.
Now let me ask you one thing. I saw your lecture this morning on smoldering multiple myeloma, and I kept thinking afterwards, maybe should we start, I'm going to be bold here, screening the population and then separating the high-risk patients for therapy with smoldering myeloma, trying to treat everybody with myeloma before it became symptomatic, try to find all possible smoldering myeloma cases before they develop organ lesions so that maybe we could better improve outcomes. I don't know, I'm thinking outside of the box here. Just what do you think about screening for smoldering multiple myeloma?
Yeah, excellent question. And I have written a paper about it. It's called The Screening Imperative in Nature. If you Google it, you will see what my thoughts are. And I'm thinking exactly the same. There will be a time when we have enough data that treating high-risk smoldering myeloma, high-risk smoldering myeloma is beneficial, and everybody agrees we should treat. In that sense, the only people we'll treat will be those who you're accidentally finding. How are we going to help all the people who have high-risk smoldering but are not yet diagnosed? That's 0.5% of the general population. So I'm reluctant to recommend screening. It's a bold idea, what you said, for everyone. because until the iStop trial, and Dr. Christensen said he may have the answer even within 2 years. They've screened the whole population of Iceland. One group is just not, they don't even know they have anything. The other group they're following closely, and the other group they're following even more closely and intervening early. So if that trial shows a benefit, not just in identifying the diagnosis, but in survival, then we can, or even PFS, then I think it'll be an important reason to say we should screen. Until then, in this paper, what I argue is, Sigurdur today, he said he wouldn't like to screen anyone yet until that trial. But I feel like we should offer screening for high-risk smoldering myeloma to patients who have 2 affected relatives with multiple myeloma, because there are some families where there's a lot of relatives who have it, and we know that MGUS occurs at 2 to 3 times higher rate in people who have a first-degree affected relative. So knowing that, I think if somebody has 2 affected first-degree relatives, I think we should offer screening. That's what I write in that paper. I think we should also offer screening to people of Black ancestry who have even 1 affected relative, because even without an affected relative, they have 2 to 3-fold higher risk of myeloma if they have another affected relative already. Like if you're Black and you're 50 years of age and you have some cousin some brother, first degree, who has myeloma at age 55, I mean, the SPEP is not the end of the world. You can just quickly screen, and that reassurance will probably give thing. And if there is something, it's not the end of the world to monitor MGUS. So I feel like for first Black individuals who have 1 affected relative, or all others with 2 affected relatives, starting at say age 50, we should consider screening.
The future of autologous transplantation. Would you like to comment in our setting today, multiple myeloma, the role of autologous transplantation in the future? What would you like to comment?
Well, the number of transplants done is slowly coming down for the first time since the publication of the IFM and the determination trial. We still recommend an early transplant for all patients who are high risk, so that's easy. For the standard risk patients, if they are eligible, we tell them it's good for them to get a transplant at some point. And so we collect stem cells and store it for those who don't want it now, and those who are happy to do it now, we are doing it. In the future, things might change, but for the time being, I think the main question is not whether to do a transplant, but rather when to do the transplant. For the standard risk, I'm willing to let the patients be involved in the decision making, looking at age and everything else also. And for the high risk, prefer the early transplant. One thing to keep in mind is like the data with Perseus is really quite striking. DERA-VRD, transplant, maintenance. 90% of people are alive at 4 years in the transplant eligible group. 85% are alive and free of progression at 4 years. It's hard to tinker with that right now. If the patient wants a delayed transplant and the standard risk, as long as you're going to do the transplant later, it still is okay. But other than that deviation, I would stick to keeping it in the mix for now.
Thank you very much for your time here. I just want to make one last question, but now it's not about myeloma. I saw that you and Renato were playing yesterday. You guys have sort of set up a myeloma band. And how long have you played instrument? And do you like music? What's your favorite music style?
Yeah, I like music since childhood, more into singing, and that to Indian music rather than playing instruments. But I've been playing guitar for a long time, rhythm. Tried to learn the lead guitar, but got it's very, very difficult to pick up at this age. I'm still tinkering with that. I tried to learn piano, and I played the keyboards for a few years with my kids when they were learning. Then I got fired by my piano teacher because I was not practicing and coming for the lessons prepared. But I have a very deep interest. I mean, I have a huge collection of music. I think I would rather be in your position where I can play the drums well than be a myeloma doctor. My God, your skills are amazing. I'm so happy.
Oh, thank you very much.
Yeah, I mean,
Any favorite band or any favorite
No, I
guitar
mean,
player?
well, I have. I love Indian music. I love Indian music very much. So that's one. I love Megadeth.
Megadeth, really?
I'm a big fan of Megadeth. I love Marty Friedman. He's the best guitarist ever. I mean, his solo is just unbelievable. And Dave Mustaine, of course, the best rhythm guitarist.
Do you know Kiko
Metal.
Loureiro, the
Pardon?
Brazilian?
Oh, Kiko.
Yes.
I've seen Kiko play Tornado of Souls note for note, along with Marty on the record, note for note, and he's amazing. I mean, Kiko's no longer with the band, which is sad.
Yes.
But Megadeth's latest album is amazing too, so take a listen.
He sells, who's buying. Okay. Thank you.
So thank you very much, Dr. Rajkumar, for being here with us. And this is a happy hour pill. It's a short version of our podcast, and keep following us on Instagram and Apple Podcasts and Spotify. And I'd also like to thank, we didn't introduce Ruddy. He is here from Rio, and he helped us setting the equipment for this short form interview. Thank you very much, Ruddy, for being here with us. And thank you very much, Professor. And we hope you enjoy the meeting. Thank you very much.
You guys, thank you.